Our group has studied this previously, particularly older patients with chronic myeloid leukemia, which is what we call a Philadelphia chromosome positive MPN, the only one. And we had previously shown that actually a quarter of patients do not receive the appropriate frontline therapies for chronic phase disease, which are the tyrosine kinase inhibitors directed against the fusion protein which drives the disease. These are the BCR-ABL1 TKIs, which we generally think induce a functional cure for many patients. There are some toxicity profile differences between the agents, and some older folks can't accept these risks. But because almost a quarter of patients didn't receive these, we want to take it one step further and say, of the patients who actually do receive these good therapies, these TKIs, well, how many are actually treated quote unquote appropriately? Do some providers have some laxity in how they're monitored or how they're treated? This is what prompted our study, which is just presented yesterday at this meeting. So we looked at just over 1,000 patients, actually the largest population-based cohort of older patients with CML that received TKIs to date. Our median age was 74 years, and I think if you look at the interquartile range, it was 70 to 80 years. So an older population. The median age of diagnosis is about 15 years younger than that. So these are older folks who are subject to unique challenges when it comes to cost issues, transportation, social support, which can impact, we think, the treatment and outcomes and how these patients navigate, through the journey of their disease. We found that among these older patients, actually only about 80% had, during the first year, had appropriate molecular monitoring. So just taking one step back, patients that are treated with TKIs for chronic phase CML should receive usually at least 3 what we call molecular monitoring tests. Usually at 3 months, 6 months, 12 months. Some folks advocate for every 3 months, including the 9-month mark, to really tell whether this TKI therapy is working at requisite points in the first year course. Tell us, is this TKI working? Is there a concern for inherent or acquired resistance, which would be early, which might inform the provider to pivot to a new TKI, or even in some cases consider transplant during the first year. Only 80%, actually 20% of patients did not receive any molecular monitoring. And we think this was a pretty high fidelity assessment, mostly because we used the SEER Medicare linked database. This is the Surveillance, Epidemiology, and End Results Medicare linked database, and a database through which we can actually glean what are called HCPCS codes to look for molecular monitoring tests at any one point. 20% didn't receive any. We defined optimal monitoring, which is kind of aligns with what I told you, checking at 3, 6, and 12 months. Or around this time, we gave some providers around 30 days of buffer zone. If maybe they checked it early, maybe they checked it late. 20% didn't receive any. Only 80% actually had any one specific test at any milestone, and 20% did not have what we call optimal monitoring. Optimal monitoring was influenced in multivariable analyses by a couple factors. The one which was most impactful was being diagnosed during a later study time period. So we studied patients from 2007 to 2017 and fell through the end of 2019. Patients that were diagnosed during a later study year during our period had better monitoring. But if you looked at the figures that we presented, even among those patients, only about 45% actually had what we consider optimal monitoring. So there was an increase during the study period, but it still was not what we would call anyway appropriate or good. In looking at the adherence patterns of patients, we found that the median proportion of days covered, or the PDC, was about 90%, which is better than we expected, to be honest with you. But we did note that there was a progressive decrease in the number of percentage of PDC as patients were less frequently monitored. These two things co-associated. In looking at the predictors of which patients are getting less PDC, which patients are actually not as adherent to their therapy, we did perform multivariable analyses and found that patients that were diagnosed in earlier study years had lesser PDC. Patients that actually had lower SES, or socioeconomic status, we measured this using the Yost index, which is an area-based composite to basically approximate socioeconomic status using a number of factors. There are more complex, less complex methods, but this is a nice one which has been used in other studies, similar studies. Lower SES predicted lesser monitoring as well, but also lesser PDC. As I said, these things co-associated. In addition, we found that patients that had received influenza vaccinations within the preceding year, or actually had an antecedent cancer diagnosis, which you could say is are just surrogates for better healthcare access in general, were more monitored. So in conclusion, there are some clear deficits. It's unclear if the deficit is truly in our data set or the practice in general. We tend to favor the latter. It's clear that patients that do get TKIs there is a majority of patients that actually don't get optimal monitoring, and a good deal of patients that actually don't actually have what we consider an appropriate proportion of adherence. So this is certainly something that surprised us, and hopefully warrants some better research to understand exactly why, to of course improve the outcomes for patients. It's really hard to derive benefit from a drug, especially an effective one, if you're not taking it.